for the very first time, welcome. You will notice that the audio and visual function for participants is disabled. However, I encourage you to use the chat box to post questions or to make comments throughout tonight's session. If we don't get to all of your questions due to time constraints, feel free to email us afterwards. And if you'd like to submit a case, and I strongly encourage you to do so, please email us at osboneecho, that's all one word, @gmail.com. This evening, we've got 3 case discussions followed by our Ask the Expert Q&A session. You can submit your questions in the chat box at any time. I'm delighted to welcome our first presenter this evening, Dr. Gerald Singh from Singapore General Hospital. He's working as a senior resident under the supervision of Professor Chandran. Welcome, Gerald. Can I ask you to share your presentation?
Thank you very much for the introduction. So I'll just begin my case. We are going to be discussing a case a challenging case of hypercalcemia today. Okay, there we go. So our case is, this is a patient, a 65-year-old Chinese male with a background of hypertension, hyperlipidemia, diabetes, and ischemic heart disease. He was admitted to our hospital in December 2022 for a right knee septic arthritis. This was quite extensive, required deliberate mourn and flap creation by the surgeons. He thereafter developed pyrexia of unknown origin that lasted since December 2022. Despite adequate source control of the initial infection, there was an initial impression by the infectious disease doctors of Clostridium difficile colitis, but the fever persisted despite adequate treatment with appropriate antimicrobials for this. He was broadly covered with antimicrobials during this time, including carbapenems, but continued to be febrile. Of more interest to us also, he actually developed hypercalcemia. His calcium levels had actually been normal on admission and on intermittent monitoring during the initial phase of his admission, with the last normal value being recorded on the 14th of February of 2.32 millimoles per liter. However, as you can see from the table, the calcium actually rose fairly fast from the 16th of February onwards, with a value of 2.62 on the 19th, 2.83 on the 20th, 2.99 on the 21st, and 3.07 on the 22nd. These are some of the other relevant investigations. As you can see here, the phosphate was not low nor high, it was kind of in the normal sort of range. He had 2 different intact parathyroid hormone measurements, both of which were undetectably low, both suppressed. Prior to this presentation with hypercalcemia, he had normal 250 microgram short synectin test done, ruling out adrenal insufficiency. The thyroid function was also normal with a normal free thyroxine and thyroid stimulating hormone. Whilst the PTH was completely suppressed, the magnesium also was slightly on the low side, 0.73, 0.6, and he did have a low or insufficient 25 hydroxy vitamin D level of 11.5. Of course, there were some medications, when we did the chart review, there were some medications that have led to or could have contributed to his worsening hypercalcemia, not least IV furosemide or diuretics given on the 21st of February by our colleagues from internal medicine, and the fact that he was on nasogastric feeding with presubin, which is a milk-based feed with a daily elemental calcium load, in his case of about 450 milligrams. Nevertheless, because of the presentation with a hypercalcemia with a suppressed PTH, of course, we are always mindful of the possibility of malignancy. We reviewed his cross-sectional imaging. Because of the fever, he had quite a bit of imaging done prior to our assessment. A CT of the thorax, abdomen, and pelvis was done on the 30th of January, preceding the hypercalcemia. This showed moderate colitis, again with a history of C. difficile colitis. Some nodules at the lung apices, but no evidence of malignancy. As mentioned, the C. difficile colitis was adequately treated, and he had actually gotten clearance from the infectious diseases colleagues. They had sent multiple sputum tuberculosis smears, cultures, and a negative PCR, ruling out TB as the cause of the lung nodules. There was a single AFP culture that grew a Mycobacterium avium complex, which is a non-tuberculous mycobacterium, but this was deemed an environmental contaminant by infectious disease colleagues as well. Then after the development of his hypercalcemia, he did have a CT abdomen of the pelvis. This showed a new finding of extensive omental and peritoneal fat stranding. There were nodularities, small volume, as well as some free fluid to suggest peritonitis. So the infectious disease impression at this point was that of possibly TB peritonitis, And so he was planned for actually a PET CT to look for other lesions, as well as a biopsy of the peritoneum. A PET CT was done in quite short order. This showed it was reported as having interval appearance of marked areas of moderately FDG avid omental and peritoneal fat stranding and nodularities. Again, suspicious of infective peritonitis. He underwent peritoneal exploration blind on the 25th of February. This was essentially negative. There was a lymphocytic eel, but there's reactive cells, and all the microbiology, including all the smears and cultures and stains for TB, were negative. He then underwent a radiologically guided peritoneal biopsy. So from the initial ones of acidic fluid, he had a biopsy of the peritoneum itself, which showed essentially just fat necrosis with no evidence of granulomata or malignancy. Again, all the microbiological investigations were negative. Because we were quite desperate to look for the cause, and because the clinical suspicion was high, and also he was unwell at this point in time, as I will go on to share later, he had a surgical peritoneal examination and biopsy done on the 17th of March. Again, the surgeons reported the peritoneum as looking very normal looking with no nodules. There was on histopathological examination diffuse fat necrosis, including granulomatous inflammation, with some secondary reactive changes. But again, all the microbiology, including TB stains, etc., were all negative. Other investigations were performed to evaluate for the cause of this hypercalcaemia. First, a parathyroid-related peptide was sent, but this again was low below the reference, 0.5 picomoles per liter below the reference range of 4.2. We did also send a 125 hydroxy vitamin D, hydroxylated vitamin D, which was kind of normal, high normal, at 52 picograms per milliliter with an upper limit of the reference range of 64. Of note, this was sent when the 25 hydroxy vitamin D was 11.5, very insufficient. He had a borderline elevated serum angiotensin converting enzyme level of 89 units per liter, which was just above the upper limit of normal of 85. However, when we consulted rheumatology, they thought sarcoidosis was extremely unlikely in this patient because there was no evidence of granuloma on any imaging or histopathology, which suggested against the diagnosis. And we do know that ACE is not a specific test, from what I understand. Serum protein electrophoresis was done to look for myeloma. This indeed did show a monoclonal band, and the suspicion of possible MGUS was raised, or even myeloma was raised. Bone marrow aspiration was performed. This showed hypercellular eel with plasmacytosis of 15%, but notably this was polyclonal and not monoclonal. And the trephine was subsequently reported to have a plasma cell population indistinguishable from a reactive population. And the hematologist again also ruled out by possibility of multiple myeloma, although MGUS was not excluded. He did also again have no bony lesions noted on imaging at this point in time. Lastly, he was ill in the ICU for a separate infection, and so bronchoscopic lavage and a fluid drain were inserted. Again, all of this was negative for malignant cells or infection, including that of tuberculosis. So this is a bit of a busy slide, but it summarizes kind of his corrected calcium trend as well as all the treatments that were rendered to him. In the bottom row, I suppose, we can see that he was unwell for a while in the ICU and the high dependency unit with respiratory failure from a lung infection, as well as some degree of fluid overload, possibly because we had aggressively tried to resuscitate him to correct his calcium. He did receive multiple doses of antiresorptives. He got a dose of IV zoledronate on the 24th of February, shown in the first arrow. He then got successive doses of denosumab. Split dose was initially given because of concerns of renal impairment and low vitamin D, but rapidly topped up to get the full 120 dose. And he got this again at weekly intervals for a total of 3 doses. Despite this, the calcium continued to rise, reaching a peak of 4.2 millimoles per liter, 4.1 millimoles per liter, and therefore the decision was made to start him on hemodialysis in the ICU. This actually did lower the calcium levels as one would expect, and he was also started on empirical treatment for tuberculosis by the infectious disease doctors halfway through the course of his ICU stay. After the completion of hemodialysis, the calcium did remain fairly well controlled at 2.8, but then began to rise very rapidly after a couple of days. And that was when the decision was made to give him a trial of high-dose glucocorticoids for the suspicion of 125 hydroxy vitamin D mediated disease. As you can see from the graph, actually, this seemed to have worked quite well. The calcium level slowly did come down over the ensuing couple of weeks, 2 to 3 weeks, and did stabilize at between 2.5 to 2.7 millimoles per liter. CT of the abdomen and pelvis was done at the end of his treatment, which did show increase in the peritoneal fat stranding and no other features then. After the glucocorticoids were stopped, he remained, he had a relatively normal calcium for about a week or so, but then the calcium level started to rise again. At this point, he was also noted to have postural hypotension. At 8 a.m., cortisol was sent, 92 nanomoles per liter, highly suggestive of adrenal insufficiency. 250 microgram synectin test was also performed, with a peak of 218, so confirming the diagnosis. He was therefore started on physiological glucocorticoid replacement at this point, and this actually did help to lower the calcium level slightly. And I just repeated a measurement today, which is 2.6 millimoles per liter. Of note, also, he had a 125 hydroxy vitamin D level repeated, and this was about a week and a half or 2 weeks after he had finished the glucocorticoid taper, and it was 16 picograms per milliliter from the earlier value of 52, so it comes down quite substantially. The last thing to note was also that he was not hypercalciuric. The calcium measurements were only repeated after some period of time because, the urine calcium measurements were only done after some period of time because he did have some degree of acute renal injury from his initial hypercalcemia as well as his lung infection when he was in the ICU. He was also on dialysis at that point, and he also had received multiple doses of denosumab, which can alter renal calcium excretion. So at this point, we kind of stopped and thought about what the causes of calcium hypercalcemia in this patient could be. And Dr. Manju actually has taught us a very useful mnemonic. It goes man, crikey, and gosh darn, which I understand are very Australian terms of phrases. But going through the causes, they are as follows: medications, including thiazides, lithium, or milk alkali syndrome, immobilization, granulomatous disease such as sarcoidosis or tuberculosis, osteolytic metastasis, whether hypercalcemia is spurious, the possibility of hyperparathyroidism or humoral hypercalcemia or malignancy, vitamin D toxicity, vitamin A toxicity, Addison's or acromegaly, renal failure, other neoplasms like Hodgkin's disease, lymphoma, and other rare causes including breast cancer, pneumocystic pneumonia, vaginous granulomatosis, cat scratch fever, hepatic granulomatosis in patients on chronic dialysis, talc, and other rare congenital disorders. So we were wondering then, what is the likely etiology of the hypocalcemia in this patient's case? Is it malignancy? But the PTH-RP was normal, and again, multiple rounds of cross-sectional imaging did not show any solid organ tumor. As described also, there was no evidence of MF, multiple myeloma at this point in time. Is it tuberculosis? Well, the initial imaging was suggestive of TB, and the calcium did improve with empirical TB treatment, but there was never any microbiological evidence of TB infection. And we also did start steroids around the same time as shortly after we had started the TB meds, so that's a potential confounder as well. Could it have been sarcoidosis in view of the mildly elevated serum ACE? As explained, we had discussed with dermatology, and the opinion was that in the absence of overt granulomata, it was unlikely. Was it possibly milk alkali syndrome? He was on a feed with a relatively high elemental calcium load initially, but firstly, he was never alkalotic, nor was there any improvement in his calcium after changing him to non-milk-based feeds. What did the immobilization contribute? He was very bedridden, and he's been in hospital for essentially almost half a year at this point in time, so you can imagine he's been quite debilitated from that. But the 24-hour urine calcium is normal. And even if it were the cause of hypercalcemia or were a contributor, it was unlikely to be the sole cause of hypercalcemia in this case. Would dehydration have been a factor? The calcium did rise every time we tried to tail fluids down, but again, it's unlikely to be the sole cause of such severe hypercalcemia. Would adrenal insufficiency be a consideration? But he did have 2 normal post-intravenous stimulation tests twice prior to his initial episode of hypercalcemia. Yes, he did develop adrenal insufficiency thereafter, but it was likely only after having been administered high-dose steroids for a period of 2.5 to 3 weeks. So then that leaves us scratching our head. What else are we missing out on? So after thinking very hard and looking at the imaging, we thought that the likely cause perhaps could be this entity that has been described, sclerosing mesenteritis or mesenteric panniculitis, which is in keeping with his imaging features of diffuse peritonitis and the biopsy showing endocrinologist inflammation. And interestingly, although this is a fairly poorly described pathological entity, some authors have described it as a multi-stage process, with the middle stage or stage 2 being characterized by inflammation and lymphatic dilatation, but more relevantly, increased macrophage infiltration. And this phase of the inflammation is called mesenteric panniculitis. And we thought perhaps this might be the cause, considering that we know that 125 mediated disease is macrophage mediated. And you know, his 125 hydroxy vitamin D levels did improve with steroids, as one would expect, but that also showed was consistent with the overall improvement in his hypercalcemia. But the question that I would have to ask this expert panel is whether or not there could be any other etiologies for hypercalcemia that we are missing and we should look into. And in such a case, what might the long-term management be beyond close observation and re-challenge with high-dose glucocorticoids should the hypercalcemia recur? Again, as mentioned earlier, his calcium levels are still not completely normal, 2.6 millimoles per liter. The upper limit of normal in our labs is a bit tight, but it's 2.48 millimoles per liter. So he is still hypercalcemia at this point, although we are keeping it at a fairly safe level with oral hydration at this point in time. So that brings me to the end of my presentation. I'm happy to hear from our expert panelists.
Great, thank you so much, Gerald. That was a really well done and comprehensive and systematically described presentation of really quite severe hypercalcemia. Manja, you know a lot about this case, so I might start with Ian and Christian for questions and comments, and then come back to you, Manja, if that's all right.
Yeah, of course. I mean, that's what I want Ian and Chris to kind of comment.
And maybe Christian, you're unmuted. How about your thoughts and comments first?
Sure. Look, I must apologize. Actually, for the first half of the talk, my audio wasn't working, but I got the actual gist of it. So, look, it's a quite a challenging case there, Gerald, and it was very, very well put forward. So, thank you for that. So, I think essentially you've got some sort of macrophages or sort of lymphocytes in that tissue that are actually activating vitamin D, really. And I think the fact that it actually responded so sort of rapidly to the steroids is quite clearly that was the underlying cause of the hypercalcemia. I've never heard of this sort of condition in the past. Have you seen it before, or how did you come across it? Was it on the basis of the biopsy? I assume there was a biopsy here as well of the tissue in the
It was actually suggested by the radiologist. Then we went back to do our own kind of literature search. Again, it's not very well described. So it is a imaging finding that various radiologists have described variously. There have been some case series published where people have used steroids to treat it, but also some other people have said that it's a self-limiting condition. Again, there's not much information about it, and apart from one pathological series, the information of which I have mentioned here, not very much has really been described about it, and certainly not in association with hypercalcemia in the past.
Yeah. Is there any idea what actually drives the inflammation here? Is there, what's sort of precursor cell or any underlying process that we could target? Perhaps we can ask Ian about that in terms of some of the actual biologic agents that you might use in RA. If there could be one, if you knock out perhaps the beta cells, if that might help in the way this condition actually behaves. Is there any idea about that in what we know in the literature?
Not to my knowledge.
Yes, I mean, I've got to say, sorry, Gerard and Christian, do you want me to say something at this stage, or you want to keep on going, Christian?
Look, I think at this point, I mean, I've not heard of this condition before. I think the only thing that I can say at this stage is that it's actually mediated by the activation of vitamin D, by ectopic, 1-alpha hydroxylase. I think steroids really are the only way that you can mitigate that in the acute setting. Thinking of what you can do to actually address the underlying sort of lesion itself, if that can be targeted in some way that would stop the whole thing from, I suppose, getting any worse.
Sure. I mean, look, I don't really have much to offer because, number one, hypercalcemia is not my area, and that's what I always refer to you guys, the endocrinologists. But the other thing in terms of mesenteric panniculitis, is very rare. I mean, I have seen a number of cases, never looked after a patient myself, but my understanding is it's a rare idiopathic inflammatory disorder. It's only made at surgery when they actually take out a large amount of the mesentery to have it examined. It can be self-limiting and often no treatment is required. We've been asked to do consults on these patients from the surgeons, and oftentimes the acute crisis is settled and we just go and assess them and follow them up, and they've been followed up to see if there's any recurrence of the problem. There is no information that I'm aware of, Christian, regarding biologic therapy for this condition. It is very rare, but I'd certainly ask Gerald and Manju if they've heard any cases reported, cases reported with biologic therapy.
Yeah, no. That's what our dilemma is too, Ian, because I mean, as soon as we taper the steroids down, it flares up again. I mean, the hypercalcemia goes up again, and he's on, because now he has an adrenal insufficiency. He's on physiological doses of steroid replacement, and that's barely keeping his calcium, and it's still above the upper limit of normal. So anything which kind of tips him over dehydration, anything like that could tip him over into, again, frank hypercalcemia. So like Gerald showed, we kind of went through this exhaustive list of all potentially known causes of hypercalcemia in this particular individual. And, this is the only thing that, again, because right from the beginning, we were thinking that, that 125D of 54, which was taken when the 25D was extremely low, was still quite on the upper limit of normal. And this rapid response to steroids, and once the vitamin D deficiency was corrected, the rapid response to steroids of the 125D kind of clinched in a way that this is a 125 mediated process, contributed by probably the immobilization and the dehydration, all that probably contributed to it. But our question is, long term, what do we do? We can keep him on the physiologic dose of steroids, but that is not even enough to kind of keep him, suppressed. And we don't know of any treatment, at least so far, as to for the mesenteric panniculitis per se. I mean, apparently steroids has what's been given, So but like you said, because it kind of limits itself, usually a short dose of steroids is enough. But
so can I just ask Gerald and Manju? So what was the dosing of steroids that he got? Not the physiological maintenance dose that he's getting now, but the actual therapeutic doses. How much did he get, and how long did he get it for? And
3 weeks, right, Gerald? And we bombasted him. I think we lambasted him with steroids. I mean,
So he did start off. He was given IV hydrocortisone for a short period of time when he was in the ICU and intubated. A dose of 150 milligrams a day, and that was converted to oral prednisolone at a dose of 40 milligrams. Each dose step was kept for about 3 to 4 days, 40, 35, 30, 25, and so on. So the overall duration was about 2.5 weeks 3 weeks from the 26th of March to the 18th of April.
And that did bring his calcium down.
Yeah. So, I mean, I'm just, okay, because I can't think of any sort of objective evidence to base this on, but just in terms of like dealing with something which is very rare and a very unusual manifestation. And so can I just clarify one thing? Because are there any case reports of this panniculitis causing hypercalcemia? Has that been reported? Oh, okay.
No. But so the reason why we suspected was because, the macrophage, this thing, and the 125D levels, which were high, and the fact that it responded. So, there aren't any case reports. So that's why this is a really challenging case.
So I got to say, please understand that there's no objective evidence for this, but just saying in terms of dealing with a very difficult, unusual problem, an approach may be to give a lower dose of prednisone, like 15 to 25 milligrams a day, with a much more gradual taper, and watching his calcium over time. Now that also depends on what the septic arthritis is doing. I mean, has he completed the 6 weeks course of antibiotics for that? And is there any metastatic infection? Has he got endocarditis from the staph aureus that he had, or metastatic side. I mean, you've done a PET scan, so that would have picked up any metastatic infection. I mean, it's really, really difficult.
Yeah, and actually, Ian, that's a good point, because at one point we were, I mean, I usually give much higher doses of steroids, for hypercalcemia, which is mediated by, 125D. But in this case, because he was having a rip-roaring infection at that point, that's why we were deliberately kind of holding ourselves back a little bit, and not the usual high doses that we usually give. But it did respond. Even to that, it did respond. And right now he's on physiological doses. The question is long term. I mean, I had not thought about these immunologicals, Chris, though. I mean, and I wonder, I mean, we would have to go out on a limb and do it, though, if really, because it's never been reported before, but we're really stuck.
I think it'd be good to know what the underlying problem is here. What's the underlying driver of this condition from like an immune standpoint, and if that could be targeted at the origin. The other question is if you could consider any other any other steroid sparing agents, like azathioprine.
Okay. I mean, we can look up, Gerald. We can kind of see what the gastro folks kind of say. I mean, about the mesenteric panicolitis and any other similar kind of disease which has been treated with a steroid sparing medication, because they're long term. We really don't, and he's not very old, so it's not like so that's we can look into that, Gerald.
It sounds like a vitamin D, an activated vitamin D antagonist is really what you need. But I don't know if there's any experimental studies.
Google search on that, actually, Michael. I couldn't find anything on Google or on PubMed on that just a moment ago. But I know that we use steroids sometimes to actually diagnose this sort of hypercalcemia. But yeah, I agree, actually, Ian. If we can get to the lowest possible dose of steroid and see how he goes, and maybe consider a steroid sparing agent at this point. But I mean, in some way you can actually target the actual lesion sort of surgically. Is it a large mass there that can be actually resected? I mean, I hate to think that it would get worse if you do that, but could you do that? Is it?
No, right, Gerald? I think,
it's the whole peritoneum that is inflamed, essentially.
Yeah. So the only problem is that, the steroid sparing agent might work for the mesenteric panicolitis, but whether it'll target, 125D, that's the problem, right? I mean, that's the question too. So even if we were to think of a steroid sparing agent, whether or not that will have an effect on 125D, I'm not sure, because we never talk about, steroid sparing agents as a treatment for hypercalcemia, which is 125D mediated. So that's the only other problem. Yeah. So it's a stumper.
Well, the thing about that, sorry, Manju, just to add something to it, is that, I mean, of course, we all know steroids have got all the issues of side effects, and in this guy, there's the background infection that's there as well. But the other thing is that you've got a lot of flexibility. You can go down quickly if you're running into problems.
Yeah, because he's still in the hospital.
Right. And so, but the other thing with the steroid-sparing agents, mycophenolate, azathioprine, the sort of drugs that we use a lot, I mean, there's a lag time. You're talking at least 4 to 6 weeks before they start to work. They each have their own risk of side effects. I mean, those ones have got actually significant risk of side effects as well. Infection. So, it's really not easy. I would have thought that, using the prednisone, the steroid to you can adjust up and down, see what the lowest dose is that you can get away with, do a gradual taper. And of course, the key thing in this guy, he's going to need very close follow-up and very regular blood tests to see where he's going.
Yeah. The other problems that are compounding it is that because he's immobile and, so that is also probably contributing to his, even though the 24-hour urine calcium was normal, I don't think that's a correct kind of estimation, because like, Gerald said, it was done much later into the course. He'd already received, tons of denosumab and all that. So, but that's also compounding his, problems. He's still immobile. He's still bedridden. So yeah, but
he's the last sort of person that you want to give moderate dose steroids to, or steroid sparing agents to, but you might be forced to do it.
Okay. We'll look into that. We'll see.
question for the endos. The adrenal insufficiency, where does that fit within the unifying diagnosis? How can you apply Occam's razor here and make that fit? Or is that due to something else like sepsis or potentially undiagnosed TB, or where does it fit?
That probably, Gerald, you want to kind of answer? I think Gerald did bring that up. I mean, that started only after he got the high dose of steroids. So before that, the Kozan stimulation test was normal twice. So, but that is also probably now the adrenal insufficiency. In between that adrenal insufficiency, it's all a muddle really. But we don't think that the adrenal insufficiency is responsible for the hypercalcemia. Definitely not, because previously it was a normal. He had a normal Kozan stimulation test, and it started only after he received very high dose of steroids. For almost a month, 3 weeks or something, 3-4 weeks.
Mm-hmm. All right, we might move on to the next case, and I encourage everyone to have a quick read through the chat because there's some really interesting comments in there as well. Thank you, Gerald. Any final comments before we say goodbye to you?
Thanks for the insights. We'll look into the case. I'll answer the comments in the chat. Thank you very much.
Thank you so much for joining us. Our second presenter this evening is Dr. Pinar Kozan, endocrinologist from Orange in New South Wales. And Pinar will be presenting a case of unexplained low bone mineral density in a 46-year-old man. Over to you, Pinar.
Excellent, thank you. Can you hear me? Can you hear me?
Yep, loud and clear.
Yep. And can you... Oh, can you see my screen?
Not just yet.
No.
Let's see. If you can't get it to open, I can try and open it on my screen, and you can just tell me when to change slides. How's that? Can you see that? Is that coming up?
Yeah, I can. Just give me one sec to... Yep, perfect. Thank you.
All right. You just tell me when to change slide.
Excellent. So look, thank you for letting me present this case, which is hopefully a fairly simple history, but an interesting bone density result that was unexpected. So this is a 46-year-old male, pretty well guy, and he had a routine bone density and really just very routine. So his mother passed away and he went on a bit of a health kick and sort of a pursuit of wellness, and decided that he wanted to get everything checked out, including blood tests and scans and whatnot, and that included the bone density. His past medical history is significant only for a globus tumour of his right thigh that was completely excised in January this year, as well as a previous melanoma that had been previously excised. And his only fracture history was a foot fracture at the age of 15 when he'd stepped on a cricket ball. He goes to the gym 4 days a week and has for the last 3 years. He is quite into sort of health and sort of watches his protein intake and enjoys protein shakes and tries to have 50 grams of protein a day in form of protein shakes, but really denies any other drug use or particularly anabolic drug use through the gym. He's a non-smoker. He's probably had suboptimal calcium intake long-term of around 1 serve per day, and drinks around 20 grams of alcohol per week and takes no regular medications. He had a weight of 88.3 kilograms, giving him a BMI of 27 kilograms per metre squared. And there was nothing particular to find on examination. Blood pressure was 140/80, and he appeared well androgenized. Next slide. So this was his initial bone density that was done at PRP here in Orange, and on a lunar prodigy machine. And as you can see, he's got fairly unexpected low bone density, particularly in the lumbar spine, with T-score of -3.4 and Z-score of -3.6, and also osteopenia in both hips as well, with T-scores sort of in the osteopenic range there. And because he and his GP were fairly surprised by this result, he went and had a bone density at the other machine we have here in town, which is a Medix machine, and that's the next slide. And that sort of showed probably more subtle changes. So still sort of in the osteoporotic range in the lumbar spine, but maybe not so remarkable. But I guess with looking at the PRP data, it appeared like a fairly good scan. And I guess that's the machine that I would locally tend to rely on. I'll go on to the next slide. So these were his baseline investigations. So the first one is the testosterone. Now that's been done at 2 different labs. That's why there's 2 different reference ranges. And I guess I wasn't convinced that these testosterone levels were as robust as I expected them to be. But they also didn't seem like they were, that low that that they were possibly the sole cause of the low bone density. So they were lower than I'd expected, sort of sitting around the lower end of the normal range or the adult male range. This was in the context of a low normal LH and FSH, as well as a low normal SHBG level. His bone turnover markers also appeared a little higher than expected. So really with a CTX and P1NP at the upper end of reference range on 2 occasions. He was normocalcemic, no signs of hyperparathyroidism. And the 25-hydroxyvitamin D level was quite high when I met him, but he just had the bone density a month prior, hadn't had quite a panic, and had been taking quite a lot of vitamin D, which I got him to stop. And in May, the level had come down from 177 to 136. And he'd also been coming out of summer and in Europe for the last 6 weeks, so probably a lot of sun exposure also. The 24-hour urinary calcium was also probably a little higher than expected at 9.4 millimoles per 24 hours. And I've asked him to do a repeat one, which we still haven't got the result of yet. Of note, there was no signs of myeloma in terms of the EPGI, EPG and free light chains. He had normal kidney function, negative celiac serology, a normal 24-hour urinary 1-methylhistamine and serum tryptase level. He had a normal 1 milligram dexamethasone suppression test result, as well as no signs of elevated inflammatory markers or any other abnormalities with his pituitary profile. Next slide, thanks. He had a X-ray of his thoracolumbar spine, which really just sort of suggested potentially some very minimal wedging, but really only at about 10% in the T7 and T8 vertebrae. I also did an MRI of his pituitary, really given the low testosterone levels, and that showed a 6 millimeter pituitary microadenoma. He had a sleep study, which didn't show any obstructive sleep apnea. And he had come along with a body composition scan, which revealed a body fat mass of 26.5%, which isn't usually part of my regular workup. And he's actually just had so he's still waiting for a repeat 24-hour urinary calcium, but he has had the bone scan done today, which I had on my slides that I was going to share. But essentially that's normal. So we've done a bone scan that really just shows some possible sort of arthritic changes in the right foot, but no other signs of sort of any metabolic bone disease or any other metastatic processes, Paget's disease, anything along those lines. So it sort of was non-contributory. And I'll just go to the next slide. So I guess that's the sort of the case to where we've got it at the moment. But essentially, he's a fairly young gentleman at 46 with just a routine bone density with lower than expected bone density, for which I haven't been able to find a very clear cause. I guess the questions for the panel were, what else could we be looking for in terms of secondary causes of the low bone density? I guess the things that I've sort of been thinking about would be whether that level of testosterone explains his low bone density, whether I should be looking at more reliable measurements of testosterone to really assess his androgen status, whether the hypercalciuria is a sort of significant feature, which I am sort of looking at repeating, and whether, again, if that explains the low bone mass. whether I should believe the bone density and do any further imaging, either with QCT or another machine, potentially sort of giving it 12 months. And then in terms of management, so currently he's on calcium and vitamin D and doing some weight-bearing exercise, but do we consider any further therapy from there?
Thanks, Pinar. There's lots of great discussion points there. So I might throw the microphone to Manju. And Manju, would you call this osteoporosis, and what would be your approach to the management of this young man?
Okay, Pinar, yeah, thank you so much for trying to put all this together into a very comprehensive kind of presentation. But I mean, that said, I personally think, we'll kind of break it down into a few components, but I personally think that this is a typical example of a worried well. I do not think that this man has osteoporosis. First of all, he's 46. The second thing is that I would actually like to see the printouts, the actual printouts rather than the report, because you did say that the first reading, pretty much at the same time, right, done on two different machines, showed a dramatic kind of, difference, really. He's 46, so technically, at least, you should be using only the Z-score. And there was a big difference, even in the lumbar spine, it was what was reported between that first machine and the second machine. So I really, first of all, would like to see the printouts, the actual images, to kind of, see whether maybe that the first DEXA reading, whether, maybe the spine, the vertebrae were labeled incorrectly. I don't know, why there should be such a discrepancy. So that's my first point. So I would like to see the printout. I do not consider it as bone loss, because this is his very first, bone density examination, correct? And he's 46. Maybe he's always been like this, maybe, he's not shown any evidence of bone loss per se. A low bone density, a low T-score on a first DEXA does not imply bone loss. Maybe, he started off with a low T-score, so it could be just that. So that said, if I see the actual printout, and if I see that, the second, the machine that you trust, the center that you trust, if that really does show that, and the printout shows that, it was done properly, the vertebrae were labeled correctly, et cetera, and all that, then yeah, I would consider it as, and if the Z-score is below -2, I would label him as low bone density for age, or lower bone density than expected for his age. That's all I would call him as. I would not call him as osteoporotic or osteopenic, etc. And the next question was, so that's my first thing. Okay, so I do not think that he has shown evidence of bone loss. All he has shown is that one DEXA scan, which showed, a Z-score of -2.2 or something. I forget what it was. In that second machine, that's one thing. The second thing is coming specifically now to kind of, so I would want to see the printout and all that. The second question about this, whether the hypercalciuria, is contributing. Like I said, I think this is just a case of worried well. I do not think he has, evidence of bone loss. Hypercalciuria, I would like to kind of see whether it was done along with the sodium, 24-hour urine sodium was also looked at, because, as we have seen plenty of time in Singapore, idiopathic hypercalciuria is often associated with the increased sodium excretion and increased salt intake. So that's something that I would kind of look at. And I forget, yeah, the CTX, and the bone turnover markers, I know that people do place a lot of emphasis on, bone turnover markers, but bone turnover markers cannot be used to make a diagnosis of osteoporosis. So, and just because they were slightly, higher than in the upper range, of normal, I do not think that really gives you any conclusive evidence that he has bone loss. So these are my takes on it. And I definitely would not go anywhere near romosozumab and all that kind of stuff. I would wait. I would repeat a bone density test, maybe like a year or so, which is fine. If he's willing to, he seems like a very anxious personality. Yeah. If there is evidence of ongoing bone loss, then yeah, I would, start getting, worried, and I would kind of, start investigating further. But at this point in time, if he was my patient, I would stop right now. I mean, you can, and the testosterone, slightly low testosterone, you can look for evidence of, other libido and all that kind of stuff, does he have any other evidence of hypogonadism per se? And if he has, then yeah, maybe there is a role for testosterone replacement, but not otherwise, not just for this one-time lower bone density than was expected range. I would not give him any testosterone replacement. Definitely, I would not go anywhere near him with any anti-osteoporosis agents at this point.
Yeah, there's definitely no clinical evidence of hypoandrogenism. So libido, erectile function, etc. is fine. He appears well androgenized. And I don't feel that there's any other anabolic drugs being used.
Nick, you've got your hands up. Would you like to add some comments from a bone density radiology perspective?
Sure. Well, firstly, I agree completely with Manju that we really should be seeing the images, not just this case, but in all cases with bone density. It's very important to see the images because the image quality or image scanning varies a lot between centers. So you need to see the images. There are a couple of things about the images. With Luna, you need to check the point typing as well when you have unexpected low bone density. And you can't tell that by looking at the images. You actually have to go back to the scanner and get the technologist to switch it to point typing to show you what the tissue typing is that will affect the bone density. So that's one thing that needs to be done. Now, it's interesting that he is on a health kick, because one thing to think about is, has he had contrast recently? If he had a contrast before that for some other examination, then that can interfere. So intravenous contrast, oral contrast, and oral contrast can take a week to get through the system. So just make sure he hasn't had any oral contrast or some other investigation. Now, the difference between the reference range, the difference between the lumbar spine is not surprising at all. We've actually published on this, that there is standardized reference ranges for the hip in females, and in Australia, we use the Geelong reference range for the lumbar spine in females, but there is no standardized reference range for the spine anywhere. And so everyone uses different reference ranges, and the manufacturer's reference ranges differ significantly. So that could be certainly the one explanation. The other thing is that the international recommendation, the ISCD's recommendation, is that male T-scores are derived by comparing to a female reference range. In Australia, almost everyone that I know, including us, still uses the male reference ranges. Now, it's possible you need to go back to the two centers which measure the bone density and just see which reference range they're using. Are they using male or female? They're probably using male, I suspect. Of course, for Z scores, they'll always use the gender-specific reference range. Yeah, so
it is definitely the male range, and it's the combined Geelong. Yeah,
that's for
definitely male range. Yeah. Sorry.
Sorry.
I think we've just got the bone density images up on the screen there.
Yeah. When it says combined Geelong, it'll be for the hip. The Geelong never made their spine data available. And so it would be Geelong, it would be the Luna data only for the spine, sorry. So the spine. Yeah. So Geelong never made their spine data available. So the spine reference ranges are from Luna, nothing to do with Geelong. Which is the problem because there's no standardized reference range we can use in males.
And Nick, isn't it interesting that, so in Australia, isn't it, so L1 to L4, it is just reported as the combined, L1 to L4. Do you have the L1, L2, L3, L4 Pinar? Because again, when you interpret bone density scans, you expect an increase in BMD from L1 to L3, and there might be a slight decrease from L3 to L4, but in general, you see an increase in, that's all. These are techniques by which you kind of assess whether there is something going on, which can artifactually, raise or lower the BMD, etc. So that's not reported, is it? And in Australia?
Yeah, no.
Manjit, it is. I agree with you completely. They should be showing the individual vertebrae. It comes down to the different centres and what the centres do and what a particular centre.
So I think just on this screenshot, there's just the L1 to L4, but I do have L1 to L4. So they range between minus 3.1 and minus 3.6. So L2 sitting at minus 3.1, L4 sitting at minus 3.6. And the Z scores are ranging between minus 3.4 and minus 3.9. So that's on the lunar machine.
I mean, if there's more than a one cell, so I really think, and the medics, I mean, so I really think, I don't think we have time today to kind of read, interpret bone density scans. I think we should make that another date, but that's definitely something that, I would really be looking at the images, and the reference intervals was something that I also wanted to bring up. I mean, but I thought, in Australia, it's one reference range, and, so that shouldn't be a problem. In Singapore, we have that problem because we have several different machines, and Hologic, uses Singaporean reference database, for men and women. But we have some centers in Singapore, for instance, a G Lunar uses something called an E-Station reference database. And I definitely, for one, I'm not an E-Station, but, my bone density, if I was to do it at that center, it'll be compared with the E-Station. But I thought maybe in Australia, that's not an issue, and that's why I didn't bring it up. But that's also another thing which you have to discuss when you're looking at these T-scores and making a labeling a person as osteoporosis and all that based on a T-score, especially in a 46-year-old guy, a totally healthy, otherwise running around, walking around guy. I think you have to exercise a little caution. So,
We've got a couple of minutes left before we need to go to the next case. Christian, can I invite you to provide any additional comments?
Thank you. I actually agree with what has been said at this sort of far, but I think, if you can actually believe the actual bone density, then you have a guy, though, who has Z score of minus 3.6. So if that's a real value that you're actually sort of going to actually believe in. And I wouldn't reassure him entirely. I'd still like to keep an eye on him and see maybe in a year or two and just see if there's a trend. Looking also to see if he has any features of actually OI. Does he have blue sclera? Does he have joints that are very sort of mobile and so on and so forth? So it's looking at those other secondary causes, but I think you've done an excellent job in excluding any other major secondary cause. But I would keep a close eye on him, though, at this stage.
For sure.
Thank you.
Ian, did you have any comments?
Very useful comments for everyone else. I just wanted to ask you, Pinar, I might have missed this. You might have asked it or presented it. Was there any suspicion, or did you ever ask him, or did he ever admit to parenteral steroids, anabolic steroids? Because you said he's a gym, he goes to the gym, he's physically, he exercises a lot. I mean, is that something that could have maybe explained the low testosterone as well as the low bone density?
Yeah, look, he denied it, and I guess I felt that was probably true, but it's always hard to know these things. But he's very focused on health, and I didn't get the impression that he was sort of interested in anabolics at all. So it's always hard to know, but I don't think so.
I mean, I just found when people, this is not related, so I don't have a similar example to relate to your case, but I've just found that sometimes patients will deny that they've done something, or they'll say that they're taking medication, and then only months or even years later they'll actually come back to you and say, "Well, I wasn't doing what I told you I was doing." So I mean, there is that issue too, that people don't always admit up front. He might actually be very worried about it. I mean, and maybe even just raising that with him, that's saying, look, parenteral steroid, anabolic steroid therapy may have all these side effects. Think about it. If you are, don't use it. Let's just see what your bone density is like. And maybe he will admit to it later on. I don't know. But otherwise, I would say, look, I agree with what everyone else is saying. I would definitely do another DEXA on the same machine. I've got to say, Pinar, I do come to Orange, and I found that the PRP machine is very reliable, and I use them in preference to the Loomis machine that you referred to. And the way that they present their results is a whole lot better than most other places, I've got to say. And I think he did a fantastic secondary screen, and sounds like this guy is motivated enough to follow up, and he's the sort of person that would be worthwhile following up over time. And also,
Yeah,
family history. Was there anyone family history of any?
Yeah, no significant family history at all. And I guess that's sort of where I've left things with him at the moment. That I said I was presenting him, but I'd sort of said that there was low TNZ scores, but no evidence of osteoporosis. And I think we're probably just going to repeat the DEXA in a year. But I just wanted to make sure that was, I guess, nothing else that anyone else would do at this stage. Yeah.
You're great. They're always difficult cases.
Excellent. Thank you, Pinar, for your case presentation. And we might move on to our final presenter tonight, Dr. Brenda Tarr, endocrine advanced trainee from Prince of Wales Hospital in Randwick. Over to you, Brenda.
Hi, everyone. My name is Brenda. I'm one of the first-year advanced trainees at Prince of Wales. Thank you for the opportunity to present today. Can everyone see my screen?
Yep, it's coming through well. Perfect.
So I've got a case of a 64-year-old woman who originally presents in 2015 with with primary hyperparathyroidism, resulting in a left inferior parathyroidectomy. On formal histopathology, it was confirmed to be a benign adenoma. In March of 2021, she was diagnosed with osteoporosis on a bone density with a total hip T-score of -2 and a left lumbar spine T-score of -2.7, and she was given intravenous zoledronic acid 5 milligrams. In December 2021, she develops a hoarse voice and recurrent hypercalcaemia secondary to hyperparathyroidism with a PTH level of 16.8, a corrected calcium of 2.76, and a nuclear medicine scan demonstrating a left inferior parathyroid nodule. So this is her parathyroid scan back in 2021. An FNA biopsy of the lesion demonstrated a parathyroid malignancy, and she proceeded, this is on a background of breast carcinoma, where she received a lumpectomy in 2012, as well as tamoxifen therapy between 2015 and 2018. There was no chemo radiation involved. She also had a prophylactic hysterectomy and oophorectomy for family history of ovarian cancer and breast cancer, but BRCA was negative at the time. And she also has asthma. Her only medications include cholecalciferol 1,000 units with intermittent compliance, as well as a Flixotide inhaler for her asthma. From a social point of view, she's a retired English teacher. She lives at home with her husband, completely independent with her ADLs and mobility with an ECOG score of 0. Her weight is 56 with a BMI of 20.8 kilograms per meter squared. In January 2022, following this diagnosis of parathyroid malignancy, she proceeded to have a left hemithyroidectomy with central lymph node dissection, followed by external beam radiotherapy to the thyroid bed. The formal histopathology demonstrated high-grade carcinoma with capsular and perineural invasion, as well as lymphovascular invasion. Her Chi-67 was 80%. 1 out of 7 lymph nodes were positive, and the staining was positive for parathyroid hormone. She was staged as T1N1MX. There were no germline mutations in MEN1, CDKN1B, CDC73, or RET. Post-operatively, her corrected calcium improved down to 2.34 with a parathyroid hormone of 4.6. In March of 2022, she had a repeat FDG PET scan, which did not show any residual disease or distant metastases. So this is a graph of her calcium and parathyroid hormones. So can you see my pointer? Yeah. So this was when she was diagnosed at the end of 2021, and you can see her calcium levels promptly normalized following surgery. The green line is her parathyroid hormone levels, which correlate with the axis on the right side of the graph. In August 2022, she had another PET scan in the context of recurrent hypercalcaemia, which showed a new metastases in her right ileum. Her corrected calcium was 2.74 with a PTH of 14.4 at this time, and she was commenced on cinacalcet 30 milligrams second daily. Her calcium levels returned to normal within about 2 months, and she received radiotherapy to this site of metastases. She was referred to the medical oncologist, and unfortunately, there were no systemic treatment options available, and she was referred to the MOST trial, which I will talk about in a little bit more detail later. So this is the FDG PET, which was performed in August, and you can see this lesion in the right ileum lit up very avidly. So following on, you can see the trend in her calcium level over time. It started rising, and that was when she was diagnosed with metastatic disease. And when she was started on cinacalcet, her calcium levels responded quite nicely at first. In November, so just 2 months later, she was then found to have more metastatic disease in the right cervical lymph nodes, in the right ileum, the sacral ala, as well as the left cerebrum. And she received radiotherapy to all of these sites. These are some MRI.
Brenda, you just cut out. Just see, I've got the slides here. I'll just see if I can reload them. Let's try. See if this is going to work. Is that working? Okay. All right. I'll see if I can do this from memory. So in January 2023, she had admission with hypercalcaemia, found to have a corrected calcium 3.17, and by this time her PDH was grossly elevated at 20.7, and she was given zoledronic acid, and a cinacalcet dose was increased, and her calcium was trending towards normal but remained elevated by the time of discharge.
Thanks, Michael. Sorry, my internet just cut off.
That's all right. You can help me along the way. Oh, you're there now? Perfect.
Yes,
right,
I'm here.
You tell me when to click.
Okay, so I can just take over.
Okay, go for it.
Following this admission where she was given zoledronic acid 5 milligrams, her calcium responded quite quickly. However, she has had quite a tumultuous course over the last couple of months. So we will zoom in on this section in closer detail. So as you can see, her calcium corrected from about 3.17 down to 2.5 within 4 days. And part of this is due to the intravenous fluids that we gave her. Over approximately 1 month, her parathyroid hormone levels started to climb again, and so did her calcium level, and her cinacalcet was eventually up titrated to 60 milligrams twice a day. This was unfortunately very poorly tolerated and resulted in quite significant nausea, vomiting, and poor appetite. In February of 2023, earlier this year, she was admitted for the second time with hypercalcaemia with a corrected calcium level of 3.52 and a parathyroid hormone of 97, She was given a dose of denosumab 60 milligrams, and her cinacalcet dose was reduced from 60 milligrams twice a day to 30 milligrams twice a day, given the anticipated effect on the calcium level and, again, her poor tolerability. Her corrected calcium was 2.58 on discharge after 4 days. She also had a PET scan around this time, which again demonstrated a new site of metastatic disease in the posterior column of the right acetabulum and the left iliac crest, as shown in this screenshot of the PET scan. In March of this year, she was started on temozolomide based on case report evidence and in consultation with her oncologist. And because of her persistent symptoms of nausea, poor appetite with cinacalcet and hypercalcaemia, she was linked in with our palliative care team for symptom management. So looking through the trend of the calcium levels over this period of time, as you can see, the parathyroid hormone level peaked around 97, where her corrected calcium level is 3.52. And this promptly improved over the course of about 4 days while she was in hospital. With starting temozolomide, the cinacalcet dose was also reduced down to 30 milligrams daily. But eventually over the course of about 2 weeks, her calcium started to climb again. And when it reached 2.82, we gave her another dose of denosumab, 60 milligrams. Unfortunately, there wasn't much improvement in her calcium level, and she was subsequently given another dose of denosumab, 60 milligrams, on the 24th of March when her corrected calcium reached 3.15. At this point in time, her cinacalcet dose was again increased to 60 milligrams daily, but there was definitely a dose effect on her symptoms of nausea and poor appetite. Around a week later, her calcium levels persisted at 3.15, and she was given another dose of denosumab, 120 milligrams. And every time we had to encourage her to continue taking the cinacalcet because she would stop as soon as she received the dose of denosumab. Her calcium levels did respond after this dose. However, it again started to climb, and she received another dose of denosumab on the 18th of March, 120 milligrams. And there was minimal response to this dose, and her calcium climbed to 3.29, where she was given 5 milligrams of zoledronic acid and intravenous fluids in the ambulatory care setting. The last blood test we have was from the 1st of June, where her calcium level has again reached 3.15. And the plan is to hopefully give her another dose of denosumab in about 7 to 10 days' time. So her other results reveal a preserved renal function with an eGFR of 80 mils per minute per 1.73 meters squared. Her phosphate level is low at 0.46 millimoles per liter. Vitamin D level was 63 nanomoles per liter. Her bone turnover markers were performed earlier in May with a P1NP of 17 micrograms and a CTX of 133 nanograms per liter. Her repeat bone density is booked for about 2 weeks' time, so I don't have those results yet. So the most study for those who are out of Sydney is a trial for molecular screening and therapeutics. That's what it stands for. It essentially allows patients with very rare types of cancers to have their cancer analyzed for molecular genetics and to then be allocated to a potential trial looking at novel uses of immunotherapy. So this was the report that we were able to obtain for her. And importantly, it demonstrated a high tumor mutation burden, which suggested she may potentially be responsive to immunotherapy, particularly ipilimumab and nivolumab. She is currently awaiting review from the trial team regarding whether she is suitable in terms of inclusion and exclusion criteria. If she is not suitable, then the option of privately funding immunotherapy has been raised for about $8,000 per treatment. So as of the last review, she remains completely independent and well. ECOG score is probably 1, and she has ongoing symptoms of nausea and poor appetite, especially with the cinacalcet doses being increased. But she is otherwise, I guess you could say, asymptomatic from her hypercalcemia point of view. She's not confused. She's not experiencing significant pain. So questions for the panel. Firstly, from the JCEM guidelines on hypercalcemia of malignancy, they suggest quite significantly higher doses of cinacalcet may be required in management of parathyroid carcinoma, up to 360 milligrams per day. At most, with this patient, we've been able to get up to 120 milligrams per day, which is very poorly tolerated. Is there any way we can potentially improve tolerability for this patient? What are your thoughts on 2-weekly dual anti-resorptive therapy? And I guess her minimal response so far and quite refractory hypercalcemia. Thirdly, if she's not eligible for this clinical trial, then would you consider using dialysis for management of her hypercalcemia? And fourthly, is there any role in making her become vitamin D deficient to reduce at least one pathway of hypercalcemia?
Thanks, Brenda. I might go to Christian first to get your comments.
Yeah, it's an extremely challenging case. I think I'll just start off with the last question. I think if you enter her with low vitamin D, it won't help, because one of the main sort of issues here really is the bone turnover, which is being stimulated by the excess PDH. Although I was surprised to see that the P1NP was somewhat lower than you expect in this case. Was that just straight after a dose of DMAB that you tested the bone turnover markers? Because they were a bit less than I expected in this
Would
case.
have been about maybe a week after the denosumab 120 milligrams.
Yeah. So look, it's an extremely challenging case. I'm not familiar with how high you can go in terms of cinacalcet dosing in this situation. One would think that at some stage the underlying cancer would actually mutate, so it doesn't actually express the actual mechanism that would respond to cinacalcet, which is calcium sensing receptor, which is why maybe you're not getting as much of a response later on in the disease than you were actually earlier on with the cinacalcet. Do you kind of get the sense that it's not as responsive, or is she not being entirely compliant because of side effects and GI effects of the cinacalcet as you've been increasing it?
I think she is definitely less compliant, and as soon as she thinks that she can stop the cinacalcet, she will stop it, as opposed to earlier on when she would persist with taking the medication even though it made her feel horrible. Yeah,
I mean, I suppose at this stage, whatever we do in terms of inhibiting bone turnover and cinacalcet, it's all actually downstream of the actual cancer itself. And I think the fact that you've enrolled her in the MOST study and you have been able to look at the tumor burden and a certain kind of target is an excellent way to consider what to do next, really, assuming that she'll be able to actually access an immune therapy. What I would do in this setting, I suppose, is see her regularly, maybe on a sort of 2 or 3 weekly basis. In the ambulatory care unit, I'll give her a bag or two of fluid. I'd rehydrate her. I'll give her regular bisphosphonates, and maybe actually sort of in the middle interspersed with a dose of DMAB as well. So I think it would be reasonable to kind of treat her with both DMAB and the bisphosphonate, and you want to sort of get the most of the effect of each of them by interspersing them, so having one and then maybe 2 or 3 weeks later having the other. Now that's all, as I said, it's all downstream of the actual tumor itself, and the tumor may actually behave extremely aggressively. And I suppose you should actually also up the ante in terms of treating her very, very aggressively with an anti-resorptive agent, as long as you don't actually knock out her renal functions. That's the important thing with high dose of Zol at this stage. So has she had any sort of compromise in her renal function with all of the bisphosphonate that she's been receiving?
Not so much with the bisphosphonate, but with one of the emission when her calcium level was 3.52, her eGFR fell down to 30. But it did improve over the course of 1 to 2 weeks with the correction of hypercalcemia.
Yeah. And you sort of get the sense that she's a bit dehydrated if she's not eating much or drinking with the cinacalcet, making her feel a bit nauseous, because that could also be sort of driving some of the hypercalcemia as well.
Yeah, it's mainly with food in terms of her appetite, but we have been trying to encourage her to drink up to 3 liters of oral fluids a day.
Yeah. So I'll go easy on the cinacalcet at this stage, and I would see her regularly, and I would hydrate her intravenously regularly, and I would give her bisphosphonate on a regular basis with a bit of DMAB in the middle, and see how things go whilst looking at the other approach of the immune therapy. But it's a very challenging situation, and I mean, do you think she'll actually die of this at some stage? It's looking quite likely, isn't it?
I think we are quite quickly running out of management options, and the immunotherapy is essentially a last-ditch effort. But I guess it's really sad because she remains quite functional. She's not, she's still living at home with her husband, ECOG 0 to 1. So the thought of, stopping everything won't be easy.
And in terms of where she has the actual disease, so you showed that she has some in her brain, and also in the mediastinum. Is there a large enough lesion that can be sort of externally beam radiated at this stage, or has she already had some?
She's already had quite a lot of radiotherapy over the last 6 months.
Poor thing.
Yeah, she had the stereotactic to the brain lesion. She had a lot of local to the neck and to the pelvis as well. And I think they're looking at doing more up to a threshold because she did get some response to it. Manju, have you had an experience with metastatic parathyroid carcinoma?
Yeah, which is, Brenda, very, very unfortunate, sad case, actually. I mean, this is the one thing that you do not want to happen. But just a few pointers, I mean, because Christian has already kind of addressed some of the questions that you had, but a few pointers, if I may. Number one is, I mean, I work very closely with the parathyroid surgeons, both at Singapore General Hospital as well as National University Hospital. And the cardinal rule, if you're suspecting, I mean, this is kind of a retrospective kind of thing, but I mean, and it's not like pointing fingers or anything like that. I'm just kind of, just because it's a teaching kind of these sessions are meant as teaching sessions. One of the cardinal rules, that at least as far as I understand from my experience working with parathyroid disorders and parathyroid cancer, is that you try not to biopsy, you try not to do a fine needle aspiration, and because the risk of seeding is very high. Okay, so that's one of the cardinal basic rules. If your clinical suspicion of parathyroid CA is high, you go in, you open up, you look at it, bilateral exploration, and then you do all this, the central, dissection and, radical dissection, all that is necessary. But you try not to FNA, and try not to put a needle in there because that carries a risk of seeding. So that's one thing. And second thing is that another teaching point, if I may, is that, I mean, which you have correctly kind of realized, is that the patients most likely die from parathyroid cancer. This lady had distant metastasis, but in general, parathyroid cancer, most patients die from the effects of hypercalcaemia rather than, the effects of distant metastasis. She is unfortunate enough that she's had, distant metastasis too. So the diagnosis of parathyroid cancer, and this is clearly parathyroid cancer and all that, but again, coming back to the teaching kind of thing, is that, so like I said, you try not to put in a needle, you make the diagnosis clinically, very high levels of PTH, very high levels of calcium, large, palpable mass, etc., and you go with your clinical suspicion and you go in and you operate. Post the histopathology, it's a very difficult diagnosis to make histopathologically wise. Okay, there are major and minor criteria which we look at, and we have had a whole series of parathyroid cancers which we have written up actually. So this invasion, perivascular and capsular invasion, and all that are described as characteristic. But the other thing which you look for, which can serve as both as a diagnostic as well as a prognostic marker, which I'm not sure whether it was done in her case, is looking for parafibromin. Okay, so you look for loss of parafibromin expression. Parafibromin is the gene product of CDC73. So that kind of, in her case, it's kind of moot because she's shown that this is an aggressive cancer with her distant metastasis. But to find out the prognostic kind of, lack of loss of parafibromin expression is a very good prognostic marker for parathyroid CA. In fact, that should be done. And if that is, if there is loss of parafibromin, very few labs do it, but if there is loss of parafibromin, that could also be an indication to do genetic testing. And I'm not sure, I don't know whether I saw a genetic testing for MEN1 and all that kind of stuff, I think, but I'm not sure whether you did it for CDC73 or HRPT2, which should be done, which definitely should be done in all parathyroid CAs. And in the case of loss of parafibromin expression, even her family members, I would actually screen for CDC73 gene mutations, because that can be associated with parathyroid cancer. Coming to the treatment-wise, so somebody has written that, it's done routinely at RNSH. So, I mean, I definitely think that would be worthwhile, looking for parafibromin expression. What you're looking for is lack of parafibromin expression. Therapy-wise, yeah, you seem to have exhausted pretty much everything, and hopefully she can get this immunotherapy, which again, I mean, for people who are probably not in the know, I mean, this is basically immunotherapy has been suggested because, directed against the, the parathyroid per se, may work. And that's all we can hope to, hopefully she can get it. But otherwise, as like Kristen said, I would go with, alternating between denosumab and, bisphosphonates. Cinacalcet, if she cannot tolerate it, she cannot tolerate it. What can we do? I am not aware of any ways by which we can improve tolerability with cinacalcet. That is one of the side effects, the nausea and vomiting. My patients too, I mean, they hate it, so very few people, tolerate cinacalcet, even at like 30, 60, 90 milligrams per day dosage. So, the fact that she is even able to kind of handle the 120 milligram per day, I'm kind of quite surprised. They usually cannot. Nausea and vomiting is a significant limiting factor for cinacalcet.
Thank you, Manju. There's definitely been an endocrine focus to tonight's discussion, Ian, but did you have any comments you want to make before we go to the questions in the text box?
No. I mean, I have no comments because this is really not my area, and I was very interested to hear what the endocrinologists have to say. Just a question, though, that maybe we can start off the questions. In this case, what would be the maximum or the upper limit of this bisphosphonates? She was getting Zol and denosumab. So, where would you go to in terms of saying no, more than this isn't really not going to work?
I mean, if you look at the oncologists use 4 mg of Zol every month in prostate and breast cancer. So I suppose it all depends on the kidney function.
Exactly.
As long as you have high enough bony turnover, which in this case, strangely, is a bit lower than you'd expect, but I suppose maybe straight after a dose of DMAB. But if you have enough kidney function and you're hydrated, then you can have as much as 4 mg every month, if not more than that.
Yeah.
So I would just follow it because it's an aggressive cancer. So I think it's important to be aggressive in response, but of course, making sure that her renal function is not knocked out in the meantime.
Yeah, in Iceland now, this lady has got all over the place. I mean, but I mean, other things that have been tried, Brenda, in aggressive parathyroid cancer with hypercalcemia. Like I said, most people die eventually with the hypercalcemia rather than the cancer per se. Radio frequency ablation of the parathyroid, I mean, has been tried, but I mean, if it recurs, but she's had repeat, has she had repeat scans of the sesame bees? Does it show any kind of local recurrence?
The last one was in February, and it did show some asymmetric uptake, but again, it was hard to tell whether it was post-radiotherapy or pre-metastatic disease.
Yeah, I mean, so that's something which can be, if there's convincing evidence to show that locally it has recurred, though I don't think, I mean, right now it's mostly going to be palliative unless you can get your hands on that immunotherapy and try it. I mean, if there is convincing evidence that there's local recurrence, maybe, RFA, could be tried. But again, those are just like, just grabbing straws really at this point.
I think at the moment where we have disease that's spread everywhere, I don't know if
it's not going to.
It might, it certainly may help, but I think it's actually beyond that now, isn't it?
Exactly. Like I said, I mean, it's basically, I think we are kind of really grabbing straws. I mean, just to maybe extend her life a little bit, but even the immunotherapy, I mean, as you know, I mean, it's just, there are a few case reports, which I also have come across. We had this patient, she died, this was a consult that I got from Malaysia, and she eventually died. Most of them succumbed to the effects of the hypercalcemia.
If that's the case, then would you consider something like offering dialysis to get rid of that, like hypercalcemia?
But that would have to be on a permanent kind of thing, right? I mean, this is something is churning out. I mean, all her meds all over the place, they're all probably churning out, PTH and, causing, driving the hypercalcemia. It should have to be tied down to a dialysis machine probably, to get it under, normal limits. So, yeah.
Thank you all for your help with that case. It certainly kept me awake a lot at night.
I can imagine.
I was going to jump to Q&A, but we've only got 3 minutes left. So we'll have a crack at one and see if we can get through one of them. Diana's case here sounds like a good one. I have a case of a 55-year-old woman with spina bifida, surgically corrected, but with weakness from L3 down, mobilizes on crutches, no recurrent falls, no other osteoporosis risk factors. She had an atraumatic tibial plateau fracture, T-score at the hip of -2.8 SD, was given a cluster, 5 doses, no new symptomatic fractures, but a T-scores in the hip now -3.1. Arranged for a spinal X-ray, querying symptomatic fractures. If she has had new fractures, would you give a ROMO? If no new fractures, is this still an inadequate response to therapy? Would you give Prolia to build her up and then lock it in with bisphosphonate, or leave it to be monitored? She doesn't really want any more treatment. Controversial area with very little evidence. All right, Ian, what are your thoughts on this one?
So sorry, she's got spina bifida, so she is. So what's the degree of weakness from the legs down? I mean, is the low T-score really just because of immobility? So it's not actually, and no matter what you do, you're not going to make it much better. So that was my question. Yeah. So I mean, if she's got significant weakness in her legs, I mean, that would certainly be contributing to the reduced bone density. In which case, what is your endpoint? I mean, ideally, you'd like her not to lose more bone, but by the same token, she's not weight bearing through the lower limbs. If that's the case, if she's not weight bearing through the lower limbs, and so giving her, unless there was some other new fracture somewhere else, I wouldn't be able to promoting an anabolic agent. And the question would be, really, should you just be using the cluster every second year, for example, just to try to prevent as much loss as you can.
Manju?
Yeah, no, I mean, and I think Nick was also at the same time he's coming with, Diana, I mean, I think, I mean, the cardinal kind of thing is that you don't look at T-scores. I mean, when you compare bone density scans, you look at the absolute BMD rather than T-scores. So -2.8 to -3.1, of a T-score change, most likely due to, measurement, and there's so many other kinds. So never compare T-scores. I mean, I would actually look at the absolute BMD. It's just a point that I wanted to bring up in between.
Christian, any role for anabolics in these people?
I think it's important
disuse?
to see, has she actually fractured recently? I agree with Nick that although it's not a significant change from like -2.8 to -3.1, you can now actually get her an osteoanabolic, agent on the PBS, because she's now actually crossed that sort of threshold of -3 with a T-score. So, but has she fractured while on a cluster is the question. She's immobile, or it sounds like she's someone immobile. So she may stand to actually benefit a lot from, a year of romosozumab. And that's because it's an agent that actually inhibits sclerostin, which is upregulated when you're immobile. So it would be targeted treatment, and that would be far more effective than a year and a half of a PDH agent instead. So you could consider that, but has she fractured though is the question. Would you want to wait a short while and be saving up your sleeve if there's any further drop in the bone density? Sounds like she's a bit of over treatment at this point. She's had 5 years of a cluster. You may want to space it out, as Ian says. So it all depends on the fracture. Has she had any fractures? And at some point, if not now, then I think she would be a candidate for a year of romosozumab.
Excellent. We might call the meeting to a close now because it's right on 7:30. Thank you, Manju. Thank you, Ian. And thank you, Christian. Once again, there are a couple of questions that we didn't get to. So Christine and Nick, please copy and paste them somewhere and submit them again next month, and I'll try to get to them first thing. Our next meeting is on Monday, the 3rd of July, and I hope you can all join us again. Thank you once again. Have a good night.
Bye. Thank you.
Thanks, Manju. Thanks, Christian. Thanks, Ian.